Great.
Okay, Marcy.
Yeah.
We wanted to introduce.
I'll just do a quick introduction.
Amy, you want to move it?
You've got it.
Yeah. Go to the middle, so you're in.
Yes, you're gonna have that mic.
All right, welcome everyone. We're gonna go ahead and get started. For those of you who are new to the seminar series, it's the Tools and Technology Seminar Series through the Department of Computational Medicine and Bioinformatics. Basically, it's just a venue to discuss new tools, technologies, and/or methodologies that are either currently in development, maybe recently developed, or just a neat tool or technology that researchers may find of interest. So today we have Billy Pozehl and a couple other faculty and members here, I guess, who are also going to talk a little bit. And they're going to talk to us about linear programming tools for scheduling trainees in healthcare. I do want to mention there's a sign-in sheet that is going around. Please sign in. It helps us with the pizza. And with that, I'll turn it over.
Thank you. Hi, everyone. My name is Billy Pozehl. I just graduated with my master's degree from College of Engineering in Industrial and Operations Engineering. So for me, linear programming is pretty familiar, but I'm guessing for most of you it's not. So we're going to get into a little of how we're using that for some scheduling issues today. I just wanted to recognize Dr. Reddy, Dr. Siegel, Dr. Daskin, Professor Daskin, Professor Cohn, and then our other collaborators on this project are Janice Davis, Nate James, and Yikong Zhang. I'm actually going to hand it over to Dr. Reddy and Dr. Siegel to talk about some of the background and motivation for the project first. But as a brief outline, they're going to give you that background and motivation, and then I'm going to describe a little bit of what linear programming is. So I'm going to try and fit one of our undergraduate courses into about 5 minutes. And then we'll go into how we're applying that in a specific context for surgical block scheduling, and how we're implementing that, and then some conclusions and future work. So with that, I'll give it to Jake.
So I didn't want to bore people with things they already knew, but I did want to go over a little bit about how medical training happens. The story, our training methodology right now is based on William Halstead, who in the 1890s started the first surgical residency program, which was an internship where he followed around the students until he thought they were ready, and then had 6 years of residency followed by 2 years of being a house surgeon, and then you were a doctor. And it's not that different now. After undergraduate program and medical school, which if you hear people talking about M1s, M2s, M3s, that's the years of medical school. You do an internship, which is really a first year of residency, and then postgraduate year 1, and a couple of years of residency ranging between 3 and 7, and then a fellowship, which is post-residency training. Let's see. And so what we're talking about optimizing is the scheduling of educational activities between the internship through the fellowship years. And since the time of Halstead, there's developed a set of 24 medical specialty boards, that's certifications that you can have. And at University of Michigan, we have 25 individual residency programs. and 80 fellowships. These can be subspecialties. There's more residencies than boards because they can sit for whatever boards they want to, more or less. It's more complicated than that, but so about over 1,000 people are being trained to be doctors. And the reason that scheduling is important is a number of them. One of them is workflow. We want to make sure that the right people get to the right places and that we have a good, well-staffed units. The residents and fellows serve as a component of the workforce that take care of patients. And the reason scheduling is also important is that if you do it poorly, if you get a resident a schedule that has back-to-back terrible months or experiences that they're not interested, they can burn out and have a emotionally difficult time, and non-optimal educational experiences. And a third thing is patient care. Getting the right people to the bedside in the right mix with good educational experiences improves patient care, improves patient safety, and patient satisfaction, and as well as other things. So who usually does the scheduling? What I'm talking about is, and which Dr. Reddy will talk about, the scheduling of months of experiences. It's usually can be one of the residents themselves, the chief resident, someone in charge of sort of directing their peers, as well as faculty and staff. The faculty is usually the program director, and the staff is the administrators, senior administrative staff. And what do they have to do? It's basically they sit down with, at least right now, usually they sit down with a big list of people and try to figure out who goes where when. It's a time-intensive process. We actually did an MQ project where we looked at how this was done across a bunch of the different departments, and some of them had got all the different departments who were involved in training their residents together around a table and hashed it out in real time. Other people had a senior administrator who would contact all the interested party, and this complicated negotiation would try to build a schedule that worked. And it was a time-intensive process, what, about 80 hours or so, to build a schedule for one program. We have 25 of these here. There's a lot of stakeholders involved. Some people are sending us residents. We're sending other people residents, like St. Joe, for different divisions, departments. There's complex rules about who needs to be when, how many of each type of person you get at different times. And there are conflicting goals that residents want their vacation time when their sister's getting married. They want to have a week off or have a light schedule, and vacation and staffing and things like that. And there's lots of strategies that are used. And because there are so many constraints and such a complicated process, we found basically that people adopted a good enough strategy. If you could get it done and it basically worked, you were happy. And we thought that that's a good place for optimization programming to take it one step further and improve the product and make it easier. So with that, I'm going to turn over to a little bit, talk about some of the specific programs to Dr. Reddy.
Hi, my name is Rishi Reddy. I'm one of the thoracic surgeons here at the University of Michigan. How many people here have seen this TV show Scrubs? Or ER, Grey's Anatomy? Okay. So the complexity in those shows is actually really underwhelming, and I think a lot of those shows reflect what medicine was like maybe 30, 40, 50 years ago. Nowadays, in terms of surgical schedule, the surgical residency scheduling, what we just put here is an example of the type of schedule that our general surgery residents go through. And so PGY1 is first-year resident. This is a fifth-year resident. It's a 5-year training program. There are 6 residents a year. And you can see the variety of different schedules or different rotations that everyone has to go on. It's always interesting when you watch the TV shows, they're always together in one big group. It's actually not true. You can see that there's in this group alone, we have, I think, at least 12 to 15 different schedules on there. For plastic surgery, they have a whole separate rotation. Some of these overlap with the previous general surgery schedule, especially in the early years, the first and second year. But you can see over 7 years that they have different senior rotations. And the goal of these slides is not to memorize it, just to show you the complexity in terms of the problem and just to illustrate what we're going through. So again, each service requires a different resident complement. Some services require 1 resident or 2 residents. Others may require 6. And it's also a different year. Some you may have 1 year of the general surgery residents. I guess here on the white service, you can have in the SICU multiple ones. We'll go back. So, but it varies in terms of where you're going to put everyone, and it actually does become somewhat of a complex scheduling issue. So again, the traditional scheduling approach, and I did this myself when I was a general surgery chief resident at Barnes in St. Louis, is you're building rotation templates, and then what you're doing is just alternating those templates and staggering them. That's the simplest way to do it. Again, you're adjusting for coverage, educational needs, or personal vacation needs is what Jake talked about. So you may switch here and there, but then again, you're going to have people overlapping in ways that you weren't necessarily anticipating. And then at the end of the year, you're renegotiating, who wants to skip their sister's wedding, who wants to, make changes with regards to that. And so there's a lot of trading, and none of it actually works out well. In the end, I think, as Jake mentioned, that good enough mentality is actually what we've kind of drilled into the surgery residents, because you're just happy to be there and you're lucky to be there. So I think our goal here is to improve our methodology and improve our scheduling. And so I'll let Billy take it from there.
Thank you. All right, so what is linear programming? How can we actually use it in this context? Linear programming actually came out of World War II military strategy planning, and since then it's been applied to a lot of different areas, primarily manufacturing and those sorts of things, and really hasn't been used in healthcare, at least not effectively until very recently. But essentially what linear programming is a way for you to model and solve really complicated story problems. So if you remember back to elementary school, maybe middle school, you'd be sitting in math class and your teacher would give you a paragraph long description of a problem that you have to pull out the relevant information for and essentially turn that into maybe an equation or two equations and then solve for something in those equations. That's basically what linear programming is, except for instead of a paragraph, we've got maybe a novel's worth of words. Okay, and so to figure everything out, what you want to do is look at 4 key parts of any linear program. So as an example, this is a very, very simple linear program. So the first part are the sets and parameters. So we don't have any sets here because it's so basic, but sets are essentially a way for you to group or aggregate similar entities together. So in the case of our program, one of our sets is the residents. And then parameters are known numerical inputs that relate to the decisions and the sets in some way. So getting to the decisions, here in this model, we just have 2 basic variables, x1 and x2. So we get to decide what those values are going to be. But to decide what they're going to be, you need to have some decision, some influence affecting that decision, and that is usually an objective function. You want to have some objective function. Here it's to minimize a weighted sum of the 2 decision variables, so x1 plus 2x2. And if there were no restriction on that, you could just say, okay, let's make x1 and x2 as small as possible, right? You could potentially make them negative infinity, and then your objective's phenomenal. But instead what we have is a set of constraints that limit our decision. Okay, and so those are highlighted in green. We have 2 constraints, x1 plus x2 has to be greater than or equal to 5. So that's limiting how small you can make x1 and x2. And then the second constraint is that 2x1 plus 3x2 is less than or equal to 9. So that's not really going to affect too much here, since we're saying basically the sum of these has to be smaller than some value. And since we're minimizing, it's not an issue. And then finally, you have your variable restriction saying that these variables have to be non-negative. So that's a very rough idea of linear programming, a very basic example. But if we want to get into a more complex issue like surgical block scheduling, we're going to have to define a lot more. So first, let's go through our sets. like I said, we're going to have our sets of residents. So, for example, a couple of the members of the set of residents would be myself, Dr. Reddy, Dr. Siegel, Professor Cohn. You know, you're going to have a nice long list of residents. So in our problem, we have about 105 residents currently incorporated. The second set, which is really a nice feature of the model that we developed, is this set called resident categories, which basically are ways to describe residents' traits. So for example, we might say there is a trait of your discipline. So are you a general surgery resident? Are you a plastic surgery resident, vascular? Are you, you know, any number of disciplines we can incorporate. We also have another type of category, which is the level of the resident. So going back to that pyramid of training, you have first years, PGY1, you have PGY2, PGY3, going upward. And that's essentially, you know, how long you've been out of school and how long you've been in residency training. That's some indication of your skill set, just like the discipline was an indication of your skill set. We could also add in additional categories like, does Dr. Reddy like you, right? Are you a male? Are you female? All these sorts of things that we can categorize and group the residents by. We have a third set, which is our set of services that we're planning for and that we need to fill their needs. And then the set of months is every month in the year. So now parameters. So our first parameter is actually a group of parameters, ARC. So there's a binary indicator for every single resident and category pair indicating whether that resident fits into that category. So do I fit into the category of University of Michigan graduate? That's a yes, so it's a 1 for me. Do I fit into the category of Ohio State fan? That's a no, so it's a 0. Okay, is that clear how that works? It's just this a known input. We can categorize in advance everyone's characteristics. And then we have in this part of the model, we have 2 groups of bounds. So we have limits on the number of residents that can be on service on a given service in a given month that fit under a certain category. So if I'm a first-year resident, then when we're discussing the Maze service, for example, they don't want in any given month more than 2 first-year residents, because first-year residents have pretty lacking skill sets. They're not well trained at this point. They can't do much. They can't operate, and so they're very limited in what they can do. And so you want to put a limit, a bound on how many you have at any given time. You could also say I want to have 4 to 5 residents that are from the general surgery program at any given time. So those are related to our service coverage requirements. And then for our resident education requirements, we have another set of bounds, which are the number of months over the course of the year that a given resident needs to spend on a specific service. So as a first-year resident, I need to spend 2 months total on the Maze service, 2 months total on Blue service, 2 months total on White service. And so for some of these, the bounds are actually different. You might have 2 to 3 months on a given service. So that's the general gist. Are those all clear to everyone? Cool. All right. Here's where we get into things that are not known in advance of the model. These are our decision variables. So our decision is XRSM. So for every resident, service, and month combination, we decide, are we assigning that resident to the service in the month? So it's 0 if not, 1 if you are. And you know how I introduced the whole, we want an objective function to dictate how we decide these things? At this point, our model does not have an objective because it's still in development. It's still being worked through, but in the next couple of weeks, we're going to be sitting down with the program directors to figure out what are the metrics that are going to guide a decision in assigning residents to services. So here are three of the basic constraints that are in this model in particular. There are several more, and I'll describe them briefly, but for these, I'm going to kind of walk through the math to give you some idea of how we build these models in particular. So the first one is that every resident gets assigned to one service every month. We don't want to double assign you because you can't be in two places at once, and we don't want to leave you off the list of residents that are working because then you're losing out on education. So, for example, if we look at Dr. Smith and the Mays service in July, we can decide, are you being assigned to that service in that month? So it's pretty simple. If yes, it's a 1. If not, it's a 0. But we can also have the same or similar decision variables for the blue service, the white service, and any other service there is. For now, let's just assume that there's the 3 of them. And we need to have exactly one service that we're assigned in the month of July. So does anyone know, like, can anyone suggest how we would actually put those decisions together to form a constraint?
All the variables need to sum to 1.
Exactly. That's exactly it. So your decision for Dr. Smith in Mays, plus in blue, plus in white, that all adds up to 1 in the month of July. But that's just for July, right? We need to be assigned every month. So we're going to have a similar constraint. That's for August and all the way through till June. So for that single individual resident and single service, there are actually 12 constraints that get built out. And then we move on to the next resident, and we have a similar set of 12 constraints. So then now here's where we get into some math notation that I don't know if you guys are familiar with, but essentially what this is a summation over all services in our set of services of the decision variable XRSM must be equal to 1, and then that symbol is for all. So it's for all residents and all months in our set of residents and months. So if you had just 2 residents, 3 services, and 2 months, or 12 months, how many constraints are we building in total?
72.
72, right? So it'd be a pain to write all those out, right? And actually figure out, okay, this is where something goes. But we can use this notation to actually encode this in a way that's like a couple of lines of code to make for as few as 2 residents and 3 services in 12 months, 72 constraints. So it's really nice. Our second set of constraints are the resident educational requirements. So yes.
Quick question. So where in that do you model the exceptions, like not in May because of the sister's wedding?
Yeah. So I'll get to that. Essentially, we have this 3 set of constraints are not the entire thing. We have other constraints that basically allow us to overwrite that.
Okay.
So the second set of constraints are educational requirements that say, I need, over the course of the entire year, 2 months on Mays, or whatever it is. So again, going back to Dr. Smith, we have a simple decision, but now instead of going over the services in July, we're going to go over Mays in all the months, right? So we have the decision, am I in August, and so forth all the way through June. So similar to before, we're going to have our expression and sum up all the decisions and bound that. So this is saying Dr. Smith needs 1 to 2 months over the course of the year on the Mays service. And we'll create similar constraints for blue service, white service, any other service. And the bounds, those are our input parameters. We can change those uniquely for every given resident, every service. And so here's our general formula for that, is the sum over all months of our decision variable is between a lower and upper bound for every resident and every service. Finally, we have the service coverage requirements, which tell us that for a given service, we need between a lower and upper bound every month of residents that fit into a category. So this is where that ARC matrix comes in. So we just add in these parameters indicating whether a resident fits a certain category. So you can have general surgery, you can have first year, you can say general surgery first year. So you can combine various levels of categories. So does anyone have an idea of how you put these, how you incorporate the parameters into to make this decision? Essentially, you're just going to multiply the decision by the parameter, right? So it'll look something like this. So the parameter of whether Dr. Smith is a general surgery resident times the decision for him, and Dr. Jones, you add all these up and bound them. And so the general formula for that is a summation over the residence of the indicator times the decision has to be bounded. So it's pretty straightforward. It's pretty easy. These are the really simple constraints. Here's where we get back to your question of how do you create the exception. So you can have a distributed educational requirement. So this is saying you can allow for a resident to have between 0 and 0 months on this service during this time window. So it could be a single month, it could be a group of months, it could be every other month, whatever you want. But you can allow for ensuring that they're basically off that service in a given month. Additionally, you could say between these services, you need some amount of time over the course of a set of months. Similar constraints for coverage needs, so allowing for having a set of residents be across several services. So the three main services for general surgery are maize, blue, and white. So over the course of a single month, we need 5 people from general surgery first years on those services, you can say. Extended rotations are simply allowing for ensuring that residents assigned in the month of July to a certain service also are on service in the month of August. So our chief residents in general surgery, they do 2-month rotations. So to ensure that, we add in these extended rotations. Service sequencing allows you to say, I need to go onto this service before I go onto that service. Service spacing allows you, going back to the issue of burnout and working really hard services in a row. For example, if you're on trauma service like twice throughout the year, you do not want them to be back to back because that's a really tough experience, mentally and physically fatiguing. So we're going to split those experiences. And then resident pairing allows us to say, if this resident is on a particular service, then we're actually going to bring in this resident as well. That way we can pair maybe a junior with a more senior resident, or you can pair potentially a resident that's not quite as strong with one that is stronger to ensure that we're still giving adequate patient care. So how do we actually go about doing this? Well, we spent several months, myself and the undergraduate students, meeting with Janice Davis, who's the education director for general surgery, and just picking her brain, learning about the rules, what are the different things that we need to satisfy, and then we built this model. So throughout that time, we developed it and built it, and then started to actually encode this in C++. And we have, as an academic institution, we can get a license to a library called CPLEX, which is a way for you to model and then solve a linear program. And so we encoded it and then started building out our input files to allow us to actually say, here are our set of residents, here are the services, here are the rules that we have. And then in that process realized that maybe the model wasn't completely accurate, and so we had to go back and iterate on that. But eventually we got to a point where we were able to test this model on last academic year's data set, and we're able to get a feasible solution in a matter of seconds. It solves in like 4 seconds for feasibility. So it's really fast, really efficient. And now we're at the point of collecting the information for this coming academic year from all the different program directors, and we intend to present, yeah.
So are you solving a linear program or integer linear program?
So it's an integer, it's binary. All the decisions are binary, so.
So okay, so what's the complexity if you add these binary?
The complexity, Amy, do you wanna?
Yeah, I mean, integer programs in general are, they're theoretically hard, and one of the things I find frustrating about complexity is complexity says things like there exists an instance for which this problem is not solvable in polynomial time. What we have found, in part because we're finding feasible solutions and not matching some objective function, that these are solving pretty quickly. But you could devise an instance that had structures such that the integer program would run for basically forever. And so one of the challenges with a lot of these problems is there are multiple ways that you can shape these constraints. There are multiple ways you can describe the problem. And what Billy's described and what's been a tremendous effort on the part of the students is working with the program director to fully capture conceptually what are the constraints. There's a second layer, which is how do I actually model those constraints in a tractable way. And so in some cases, your first shot goes and you hit go and it's solved. In some cases, you hit go and you go and you get a drink, you get another drink, and you wait and nothing happens. And so the rules haven't changed, but the way you have to formulate them starts to change. So far with this one, we've been lucky. Check back in a year, maybe we'll be still going to get a drink.
If you do a relaxation to a continuous variable, what happens? Do you get the good results?
No. So if you think about it, if your decision variables are 0, 1 variables representing yes, no decisions. Let's take a step back. If you are modeling a problem as an integer linear program to figure out manufacturing. So if you're solving a problem where you're modeling something that has integer quantity decision variables. So I'm designing production line for Ford, and my solutions, and I relax the integrality, and I get solutions like 7,492.6 cars. In many cases, the quality will be pretty good, such that if you just round those decision variables, you can still be feasible and you'll be still close to the optimal. If your decision variables are yes, no, and you get a 0.4, what does that mean? And in a lot of cases, you will get fractional values, because what you get is multiple people who ideally would want to work the first weekend of the month. And so the model for equity purposes, if you have equity constraints that say everybody should have a relatively equivalent schedule, then what we're going to see is if I've got 4 people and only 3 weekends, I give everybody 1 1/3 or 3/4. So in general, the upper relaxation is not going to get you very far.
So we're at the point now where we're actually collecting the data for this upcoming year. So we're working with all the program directors in vascular, thoracic, plastics. I think there's seven programs total that we're actually scheduling for in general surgery. And
Your constraints include 80 hours max per week.
so this is at a higher level of the monthly schedule. We're not doing specific shift scheduling. I'm going to talk in a few minutes about some of the other projects very briefly about how we're doing some of the shift scheduling as well.
Each of the individual services will dictate how many residents they need to accomplish the workload within the 80-hour week work week constraints. So, and for those of you who don't know, the 80-hour work week constraints basically for residents in training or physicians in training for the last 11 years now, there have been rules that mandate you can't work more than 80 hours per week on average over any 4-week period. Prior to that, there were no limitations, and so
then that's really a monthly parameter.
correct. But it can actually go across any other month. So it could be 2 weeks, the last 2 weeks of one rotation, the first 2 weeks of the other. So at a chief resident level, or from a program director, all the rotations have to fit within that. You have to be compliant in that, and so it doesn't affect this type of scheduling process. So we have looked at that in other contexts.
So we'll have the information from all of the program directors in the next couple of weeks, and then we'll be building a initial schedule for their review on February 1st, or right around there, because I think February 1st is actually a weekend. And so that's going to be actually a tremendous improvement for them, because last year they didn't get the schedule out until the end of April, when they're having residents come in, the interns come in for training in mid-May. So they get very little notice of their schedules currently, and so that's one of the things we're hoping for, is to have everything finalized in the middle of February with a few months notice for everyone. So we're just going to be updating those input files and then generating the reports for them to review. So just to recap, essentially what we found is that scheduling is actually really important for a number of reasons, primarily because it affects the patient care, the training quality, and how the workflow actually occurs throughout the hospital. Moreover, surgical residency scheduling here at U of M is incredibly complex because of the interwoven programs, and to this point, it's been pretty poorly executed at a universal level. Just in general, residency scheduling is not done well, not only here at Michigan, but elsewhere as well. However, this model actually will address the scheduling needs in a pretty robust manner. So for some of the future work, we actually do need to spend some time over the next couple of weeks to define our metrics and to build an objective function. And so that's going to be a conversation that I have with all the program directors together to get something that they can, in consensus, agree this is what we should be optimizing for. We have a couple ideas for what we can do with that, but I'm excited to hear what they're going to have to say on that topic. And then, as I mentioned, it's a pretty robust model, and so one of the goals that we have moving forward is to actually apply this not just for the surgical residency program here at U of M, but potentially the other residency programs at the university, as well as at other institutions. So to get to the topic of shift scheduling, just a quick run through of some of the other areas where we've been doing linear programming to solve for the schedules. So for the pediatric medicine department or residency program, last year for the first time, students at CHEPS built the rotation schedule, this block schedule for their interns. This year we're actually expanding to all the residents in pediatric medicine, and so that project is kind of working synchronously and together with this project to make sure that everything is uniform and generalizable. So that's been a pretty interesting project to work on, which really it was born out of the next one, which is the shift schedule that we work on at CSMOT in the emergency department. So each month we work with the chief resident to build their shift schedule. So which resident is going to work each shift on every day of the month. And so that meeting, we're going to be building out March's schedule tomorrow. And that project is incredibly rewarding. We get to go into the emergency department and observe the residents. And I've actually been in there on the first day of the new academic year when someone is just coming on to their residency program, and I've gotten to ask them, so how do you like your schedule? What do you think of the schedule this month? And this person having no idea that I was involved in building it was like, oh, it's awesome. Everyone told me residency sucks, and this is actually a beautiful schedule. So to have that interaction is pretty cool. Some of the other students have worked on how to schedule patients for chemotherapy infusion at the cancer center. We've got another project where we're scheduling physicians into the operating rooms and clinic times, and then even at a higher level than specific physicians in the ORs and clinics, you can do a master surgical schedule problem of how do we assign operating time to the various surgical departments. Finally, there's nurse staff scheduling problems. So those last two have both been done in a variety of hospitals successfully and effectively. So maybe in the future we'll be doing some of that as well. But I just wanted to give an overview of all the different areas where you can apply this. And so there's a lot of opportunity to apply some industrial engineering and optimization techniques to improve scheduling for healthcare. So with that, I just want to acknowledge CHEPS, Department of Surgery, Seth Bonder Foundation, and the Doctors Company Foundation for helping support these projects. And I'll open it up to any further questions and comments.
I'm from the medical school, and one of the things we struggle with is clerkship scheduling for years 3 and 4, M3s and 4s in your pyramid.
And that's all about to change dramatically, right?
And it's changing dramatically with the new curriculum and curriculum redesign. Have you put any thought or considered extending to that domain? Or would you consider?
So I have a meeting with
We would consider. I don't think we haven't talked about it too much, at least not with faculty
But
and
you're
students.
involved with some of the redesign.
So I'm actually the clerkship director for the Department of Surgery. And so I've been on a number of the meetings involved in the curriculum redesign. So the traditional med school model has been the first 2 years of classroom instruction, and then the last 2 years of apprenticeship-based model, similar to what the residents go through. And there's a shift now towards making those first 3 years into 2 years, and then allowing for more flexibility for medical students to explore other learning opportunities during the second 2 years. So we have talked about that, and I think that I think a lot of what has been done here can be applicable to that. The hard part is that there is this morning at 11:30, coming from a meeting, there's really no consensus on what that clerkship model is going to be, or what the schedule is going to be right now for the second year med students in the new curriculum.
Yeah, I was going to say we're having to work on scheduling the new incoming M1 students, which is the challenge is adding now clerkship experiences to their first year, which has not been done in the past. So and then some of the variables in this are variable locations. There's revenue at risk because they need to be there on time, and if they're not, the physicians don't spend as much time, and so there's a lot of variables in that, which I'm sure you face the same things with residents.
And I think there's another piece that we've talked about, which from the perspective of the Center for Healthcare Engineering, it's not just about training engineering students like Billy, it's training clinical students. And so part of the discussion has been, there's a push towards things like systems thinking and process improvement within the curriculum, and how does that fit into some of these, so we've certainly had med students working with us, and we've had students come to approach us about how can I get some experience working on some of these problems from that quantitative side.
Thanks.
So do we have an exactly matched minimum set of residents? Or do we have a few extras that have to be accommodated into the scheduling? What's our elasticity for someone being ill, etc.?
Yeah, so not only illness, but things like maternity leave. We have residents that we are scheduling for that are actually out for part of the year, and because they're giving birth and need that time with the child, and so we can actually create specific rules for them that are unique from everyone else in their category. Really, like we have a chief in vascular surgery that we're specifically planning for they need certain services in the month of July and August because that's the time leading up to the birth. And so we can handle all those things. As far as elasticity of the numbers of residents, there's some tightness for a few of the services. We're going to have a lot of learners on certain services in the month of August, but it's something that we just relax the bounds a little bit to ensure that they're going to know that there's nothing we can do about like spreading this over the year, because there are contractual agreements with other institutions that we need to send residents at certain times. And so that's one of the issues where it's basically forced a lot of people into certain rotations.
And you bring up the point, which I think is an important one, of uncertainty. And so there's an added layer of, we've talked about going from linear programs to integer programs, and from integer programs, I think going to stochastic integer programs in some form. I was involved in a project several years ago with Children's Hospital of Michigan, and this notion of what do you do when a resident you were planning on doesn't arrive, and this was early 2000s, and they have a fairly large number of Middle Eastern medical students coming over for residency, and they were running into people's visa issues. So you're supposed to be on service in July, and your visa hasn't come through. And we actually went back and rebuilt the schedule to say, if you have a visa, if you're coming in on a certain type of visa, the first 3 months, we're putting you on elective services where if you don't have somebody in emergency medicine this month, we have a big problem. If you're doing an elective rotation in sports medicine and you don't show up, things don't have quite the same effect. So being able to figure out where can we build robustness into the schedule to say the places that things are most likely to go wrong, can we put the padding in there? But there's not a lot of wiggle room in terms, you can't just say, well, let's get 3 extra residents.
I would just say surgery residents don't get sick. So, or at least not that they ever not show forth. I think out of they do get pregnant now. They didn't 15 or 20 years ago, but now we make accommodations. Or it's not an accommodation, that's not the right word, but now you have to build that into the schedule, because otherwise, you can't accommodate 30% of general surgery residents are now women for the last 10 years, where 20 years ago it was probably 5%. So 5% of cardiothoracic surgeons in practice are women, 15% of trainees are currently. So how do you make those changes to the schedule? So it's surgery is easier because in terms of the day-to-day illness, it really is probably less than a handful of times out of 105 surgical residents that anyone misses a day of work for illness, unless you have a major illness. That's partly the culture and that's partly the neuroticism of what it attracts. But you can build in for some of those bigger things.
So I'm approaching this from basically a computer science student that's completely naive in medical school, and I just assumed this is how all scheduling would be done. This is the 21st century. This is how it should be done. Is this the case in other places, or are you building on models that other people are doing? Are you pioneering this, and I'm just completely out of my just don't know what I'm doing?
Pioneering. There hasn't been some of the other applications there has been work, but we really haven't seen any literature on them using linear programming to do scheduling for residents.
I've been in a number of different training programs, and when I was a chief resident at WashU, now 8, 9 years ago, I did it by hand with a big Excel spreadsheet. That was how Janice Davis was doing it as of a year and a half ago, by herself as the kind of education czar. So, and partly through our collaboration is we thought this would be something that would be of use, but I think a vast majority of programs in medicine and healthcare are doing it by hand.
Just to follow up on that a tiny bit, healthcare in general is advanced in a lot of ways in terms of their biomedical technology, but in a lot of the operational aspects. Some things that we like in Walmart, where your $2.49 roll of paper towels is anywhere in this nationwide system, but in a hospital, you cannot know where a $2 million piece of equipment is because someone took it from one room to the other. And you can't find it because the hospital is a big place and you don't know where the C-arm went. We don't that's literally, you don't know where things are. $1 million pieces of equipment. So
should have RFID.
So Mayo Clinic is having RFID. So that's something that some of the pioneers are doing. but it's certainly not widespread. And it's also indicative of a general issue, which is that there are a lot of technological advancements that are taken for granted in industry, and a very forward-thinking thing in medicine. So that's sort of a global statement about how technology is being applied to medicine. It's very uneven. There are state-of-the-art things in very low-tech industries that are not being used in medicine, which puts us back into like the Middle Ages.
So another example of that is you can log on today and find out where your Amazon shipment is, but you can't log on and find out the status of your blood test that you had done on Monday. Unless it's already been reported, but you can't find out, you know, whether it's been reported to the doctor yet, whether the doctor's read it, whether the, you know.
Yeah, that's logical.
So, Billy, at the outset, did you consider other approaches beyond linear programming?
So
Or did you
we
decide on linear programming?
so we talked a little bit about doing some other approaches, but
So, what were the main advantages of this one?
this, I think, for us, it's something that we know pretty well. Part of the thing is that a lot of this work is done with undergraduate students, and so linear programming is a course that is taught by Professor Cohn in our department.
I'm
Usually
not sure of
for-
that though. What would you use besides linear programming?
Well, I don't-
I actually don't. Other than drawing things and going, oh, darn it, erase. I'm sort of curious.
Right, so you're saying
Which doesn't mean there aren't other things. It's just I look at this and I say, well, of course, there's a linear programming problem. So what do you all look at this and say this is? What would you do?
Well, that was the question. What other approaches? And
What
are
else
the
is
advantages?
there? Mark, I don't know. I mean,
Well,
this
you know.
to me.
I mean, I think
All of
to
these
begin to get
problems
a feasible solution, you probably would want to use something like linear programming. But then, if you want to take into account some of the uncertainties, you might want to start simulating that and saying,
Sure.
okay, well, you know, suppose, you know, Amy is sick on Wednesday. What happens then? Or suppose Amy decides she doesn't want to be a doctor anymore. She drops out of the program 4 months into this. And, you know, or, you know, her husband, you know, decides he's going to take a job in Los Angeles, and suddenly she's transferred to UCLA's hospital. And you didn't know about that.
These all happen.
These things all happen. So you could build that into a simulation, and you could start to begin to address how robust the solution is with respect to certain types of uncertainty. And then eventually, I suspect you'd move in the direction that you were talking about, which is moving from linear to integer to stochastic optimization.
So that's
But I think the idea
you
was
actually
to
gave
keep
a
it
hint
simple.
of this, which is that you have some months in the rotations that are soft, let's say elective. So if you need to cover, you'll strip people from those
So there-
units to cover.
There is a float rotation for different levels of rotation. So for 1 month you're on float, which means that you could be pulled into any different rotation for a week at a time, or sometimes even a day at a time. That actually goes against the educational curriculum. And so, but having said that, that's the backup system, especially in the context of the 80-hour work week. So there is some redundancy built in to accommodate, mostly for scheduled vacations or residents are going to meetings to present or something like that with things we know ahead of time. You have that float resident or the 1 or 2 float residents that can accommodate that.
How did your models take into account something as subjective as quality of care? Because you have 2 patients, they were treated the same, and one person's going to say this is the worst place in the world, one person's going to say this is the greatest place in the world.
I don't think this takes into account that.
So this won't directly take into account. The idea is that, you know, if you can ensure that the residents don't have a brutal schedule that's just draining on them, then they're going to be more aware, they're going to be friendlier to their patients, and so the perception of better care will pull through from that.
The patient side is so subjective. It's hard because it's so multifactorial in terms of what's a positive versus negative experience,
Right.
and some of that's just set by the attending physician before they even enter the door. You know, in terms of how you set the stage and things of you can do a perfect job, and then I've heard in one of the departments
the fact that they had to wait an extra half hour or an hour to get their discharge notes from the physical therapist or pharmacist, that's what impacted their patient satisfaction score the most. And the other thing is, you can have these constraints where you say you ideally want to have 2 seniors and 2 juniors on the service at all times, and that'll ensure that there's enough expertise, things run smoothly. And it's not a hard constraint necessarily. So when you fail to reach that, it can impact care.
But then the patient might say, I couldn't possibly figure out which doctor was my doctor. I saw 4 different people.
Any other questions?
Thank you.
Thank you.
So,
I got this part.